I do have some slides. I'm not sure, but I very much appreciate you allowing me to come here and give a talk. This is absolutely one of the most beautiful places I've ever visited. It's beautiful here. Perfect. Okay. So I'm going to talk about ovarian cancer today, kind of where we are and where we are going. Of course, we all realize it's just one of the many GYN malignancies that we treat, but I kind of choose this one to talk about today. And I'm going to talk a little bit, like I said, where we are and where we are going, and then I'm going to talk a little bit about the research for my lab. So I'm going to take you back to biology class a little bit. So I like to start off with a patient story, and this is one of my very lovely patients back in North Carolina, and this is Gail, and this is a picture of her right after her surgery for ovarian cancer. And very surprisingly to me, her family actually captured her whole journey through her cancer treatment, and so they had all these pictures to share with me. So when I met Gail, she was 47 years old. She was married and the mother of 2 kids, a 21-year-old daughter and a 25-year-old son. She was from Roanoke Rapids, North Carolina, and was a real estate agent. And when she came to see me in my office for the first time, she had a 4-month history of constipation and abdominal bloating and had undergone many treatments for this by her primary care physician. And she was actually initially referred to the surgical oncology clinic at UNC, but as soon as they kind of heard her story and saw her imaging, they actually sent her right over to me because they thought it was more concerning for ovarian cancer. And definitely when I looked at her CT scan, she had 2 masses on her ovaries, she had a lot of fluid in her abdomen, and she had little tumor nodules along her bowel. Gail had actually been pretty good at going to the doctor. She was up to date on mammograms, colonoscopies, and pelvic exams. So Gail underwent surgery. She had a total hysterectomy, removal of both tubes and ovaries, and then removal of all the cancer in her abdomen. And this was followed by 6 cycles of chemotherapy. And the good news is that Gail had a complete response to treatment, and 9 years later, she's never had a recurrence of her disease. She's very active in Relay for Life at home, and she's welcomed 3 grandchildren to the world. And this is a picture of her with her 3 grandchildren. So, I think Gail's story is very typical of how women present with ovarian cancer. Unfortunately, her happy ending is not as typical as we like for it to be. Unfortunately, of all women diagnosed with ovarian cancer, only 1 out of 4 will be a long-term survivor. So worldwide, there are about 200,000 cases of ovarian cancer diagnosed and about 125,000 deaths. There are about 22,000 cases diagnosed in the U.S. every year and about 14,000 deaths. And unfortunately, 75% of patients present with advanced stage disease, where the overall 5-year survival is not great at 30 to 50%. And I think this is a pretty interesting fact to keep in mind, but ovarian cancer is 1/10 as common as breast cancer, but actually 3 times more lethal. So these are the projected cancer statistics for 2015. And so one thing to look at is the ovarian cancer did not make it into the top 10 cancers that are going to be diagnosed in women this year, but it's the number 5 cause of cancer-related death. So just some more facts. The mean age at diagnosis is 63 years old. The average risk is 1 in 70 women, or 1.8%. However, if you have a first-degree relative that has ovarian cancer, your risk actually increases to about 4 to 5%. So on this slide, I put some of the risk factors we know that are thought to be associated with ovarian cancer. One of the theories of how ovarian cancer develops is due to incessant ovulation, leading to trauma to the ovary and ultimately the development of a cancer. So anything that is thought to decrease the number of times a woman ovulates over her lifetime, we know will decrease her risk. And these are things like pregnancy and breastfeeding, where a woman actually takes a break from ovulation. And we also know that oral contraceptives, which actually suppress ovulation, actually reduce the risk of ovarian cancer as well. And then anything that increases the number of times a woman ovulates during her lifetime will increase her risk, such as never being pregnant. We also know that tubal ligation and hysterectomy reduces the risk of developing ovarian cancer even if the ovaries are left in place. And being overweight or obese is also associated with increased risk of developing this disease. Ovarian cancer is also associated with a number of genetic syndromes, with BRCA1 and 2 high-risk mutations being at the top of that list. And the BRCA1 and 2 high-risk mutations have gotten a lot of press lately through Angelina Jolie, who bears one of these mutations. The one thing to bear in mind is that less than 10% of all ovarian cancers are actually due to genetic syndromes, so the vast majority are sporadic. So ovarian cancer is often thought of as being a silent killer. However, when you really talk to women after they've been diagnosed, many have had symptoms for many, many months. And these are things like abdominal pain and swelling, GI complaints, weight loss, abnormal bleeding, some urinary symptoms, pelvic pressure, backache, even a mass felt by the patient themselves. But these symptoms are inherently vague, so they're easily dismissed by women. We think, oh, we're just getting a little older, we're getting a little bit more fluid on our abdomen, and they don't really think necessarily to talk to their doctor about it. And the other thing is, many times I think doctors hear these symptoms and don't think of ovarian cancer as a possible cause. So currently, there are no available techniques suitable for routine screening for ovarian cancer. On this slide, I put two things that have been looked at for ovarian cancer screening. One is CA-125, and we know that CA-125 is a serum marker, so a marker in our blood, and we know it's increased in the vast majority of advanced ovarian cancers, but actually only increased in about half of early ovarian cancers. So if we use CA-125 for screening, we would inherently just miss 50% of the early ovarian cancers. And the whole point of screening is actually to catch the cancer early where we can do something about it. On the other hand, CA-125 can actually be increased for reasons other than ovarian cancer. So other GYN reasons such as fibroids, an ovarian cyst, endometriosis, and then other non-GYN reasons like liver disease or kidney disease. So actually the specificity and sensitivity of a CA-125 is not great, and the positive predictive value is about 30%. And what this means is that for every woman diagnosed with ovarian cancer, 30 other women are going to have a false positive test. And this is going to actually cause quite a bit of anxiety and potentially unnecessary surgery. So pelvic ultrasound has been another method to potentially use for ovarian cancer screening, but ultrasound is great at telling us someone doesn't have ovarian cancer. So if the ovaries look normal, if there's a simple cyst on the ovary, but it's not very good at telling us if a complex cyst on the ovary is actually a cancer. So CA-125 and pelvic ultrasound have also been looked at together, but once again, so far increased harm, meaning too many surgeries, and no improvement in early detection or survival rates. So actually just this week in the Journal of Clinical Oncology, there was a reported study from the UK that used a new logarithm of serial CA-125s with imaging in that, and they have had a much higher and better early detection rate, so hopefully there's going to be more to come for that. So why do we care so much about diagnosing ovarian cancer early? Well, if we diagnose it early when it's confined to the ovary, the 5-year survival rate is quite good at 93%. So that is much better than the 30 to 50% I talked about for advanced stage disease. However, currently, only about 15% of all cases of ovarian cancer are diagnosed at this stage. So the best we have for screening right now is to pay attention to these symptoms: bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, and urinary symptoms. And these are definitely symptoms you should talk to your doctor about and probably warrants an ultrasound. So as far as management for ovarian cancer, it's usually a combination of a surgery, hysterectomy, removal of ovaries and fallopian tubes, and what we call a debulking procedure, where we try to remove as much of the cancer as we can. And we know the more cancer we remove, the better women do. And this is combined with chemotherapy, so we have to do both. Radiation is not often used in the treatment of ovarian cancer. Ovarian cancer tends not to be very radiosensitive, so only used in very special cases. So in the beginning, chemotherapy was very toxic for ovarian cancer. We used things like nitrogen mustard and alkylating agents, and not only were these drugs very toxic, but actually the response rates were pretty poor. And then in the 1990s and 2000s, 2 drugs came into play for the treatment of ovarian cancer: taxanes and carboplatin, and these really improved outcomes for women with ovarian cancer. So when a woman with advanced ovarian cancer is diagnosed and she's treated with aggressive surgery as well as Taxol and carboplatin treatment, which can be either given intravenously through the vein or a combination of intravenously and intraperitoneally, where the drugs are delivered in the abdomen, the response rate is actually quite good at 75%, and these 2 drugs are very well tolerated. The hard thing is, and the thing to remember, is these are not cure rates for women with advanced stage disease. 75% of all those women we get into remission will recur, and it will be very difficult to get them into remission again. So definitely improvements are needed for treatment. So now I'm going to talk a little bit about our research on metformin, and many of you may be familiar with metformin. It's an anti-diabetic medication from the Bae-Jump class of drugs, and it's actually one of the most commonly used treatments for type 2 diabetes. And the interest in metformin as an anti-cancer therapy started with actually epidemiological studies that showed that metformin use may actually lower cancer risk and reduce cancer deaths among diabetic patients. And given this promising epidemiological studies as well as promising studies in the lab, there are actually greater than 80 clinical trials ongoing in regards to metformin in cancer, including translational and preoperative window studies, treatment trials, prevention trials, and survivorship trials. And there are currently 4 ongoing trials of metformin in ovarian cancer, including the one that's open right here in Orange County. So these are some of the studies looking at metformin and ovarian cancer outcomes. And in the first 2 studies, metformin use was associated with better survival in women with type 2 diabetes on metformin versus diabetics not on metformin, as well as non-diabetics. And then the last study showed that diabetics taking metformin at the time of diagnosis had half the risk of dying when compared to non-metformin users. So how does metformin work, or how does it treat cancer? So metformin is believed to have both indirect and direct anti-tumorigenic effects, although this remains quite controversial. As far as indirect effects, these are thought to occur through an improvement in insulin resistance, leading to a decrease in circulating insulin and glucose levels, which is then thought to decrease growth factor stimulation to tumor cells. On a more cellular or direct level, metformin activates AMPK, and AMPK is an important energy sensor, and this leads to inhibition of multiple pathways involved in both proliferation as well as metabolism. And actually, alterations in this mTOR pathway are very commonly seen in ovarian tumors. So when we're trying to figure out whether a drug might be good for treating cancer, we usually start with treating cell lines in culture with the drug of interest. And so this is the first thing my lab did. We took a bunch of different ovarian cancer cell lines, we treated them with metformin, and we found that metformin inhibited ovarian cancer cell growth, it induced ovarian cancer cell death, and it inhibited targets of that pathway that we talked about, the mTOR pathway that we think cancer cells use to grow. And we also found that it behaves synergistically with paclitaxel and carboplatin, which are the 2 drugs we like to treat ovarian cancer with. And what this means is that metformin actually made these drugs work better. So now I'm going to diverge a little bit back into that biology class, but I'm very interested in how obesity and diet actually affects cancer development and progression. And so for this, we wanted to move into animal models. And I used an animal model that was developed in my lab where we specifically delete 3 genes in the ovary: P53, BRCA1, which we've already talked about, and retinoblastoma. And we know that these are 3 genes that are very important in the development of ovarian cancer. And then what I did is I fed half the mice a high-fat diet and half the mice a low-fat diet and looked to see what would happen. And we found that, just like people, the mice on the high-fat diet gained weight, but their tumors also grew more quickly, and actually the ovarian tumors in the mice on the high-fat diet were triple in size to the tumors of the mice on the low-fat diet. And then mainly what I've been doing after that is trying to compare the tumors from the 2 groups to see what's different. And this is just a pretty picture that represents 131 genes that were found to be significantly up or down regulated in the ovarian tumors from obese versus non-obese mice. And we also looked at metabolic differences between these 2 groups. And there are many metabolites listed here, but probably the one of greatest interest is actually the glucose levels were 3 times higher in the ovarian tumors from the obese animals. So then what we did is we wanted to see if metformin would prevent tumor growth. And so we treated both obese and non-obese mice with this drug, and we found that metformin inhibited ovarian tumor weight and volume in both the obese and non-obese mice. However, in the obese mice, metformin decreased tumor weight and volume by 60% compared to obese controls, where tumor weight and volume was actually only decreased by 32% in non-obese mice compared to non-obese controls. And this suggests that metformin may actually be better in the setting of obesity. So we also looked at all of the tumors after treatment with metformin and found that just like in our cell lines, metformin decreased cell proliferation and induced cell death and inhibited the mTOR pathway. So we had all this great data in cell lines, we had all this great data of animals, so it was time to move to a clinical trial. But to do a clinical trial, what do you need? Money. And so at that time, Dr. Abaid, who is obviously a very close friend of mine, approached me about some generous funding from the Nancy Yeary Foundation and asked if I'd be interested in putting a trial together with her. And I said enthusiastically yes. So this led to the opening of the study that's open here, which is a phase 2 open-label, non-randomized pilot study of paclitaxel, carboplatin, and metformin for patients with newly diagnosed ovarian, fallopian tube, or primary peritoneal cancer. And fallopian tube and primary peritoneal cancer are two cancers that behave very much like ovarian cancer, and we treat all of them the same. So on this study, women get the normal debulking surgery, and they're treated with paclitaxel and carboplatin, which is our standard of care, and to this we have just added metformin. And then usually we give 6 cycles of paclitaxel and carboplatin, so metformin is given during that time, but after that we actually give metformin continuously to see if that'll help to prevent recurrences. And like I said, I'm very grateful for the support by the Nancy Yeary Women's Cancer Research Foundation for this trial, as well as I know the Hoag Hospital Cancer Center has also been helping. So far we've had 16 out of the 30 patients enrolled. They're all tolerating it very well, and we're collecting serum, urine, and tissues that will be sent to my lab to hopefully look for biomarkers of which women would most benefit from this combination of drugs, especially some of those metabolic biomarkers we've been talking about. So these are the other 3 ongoing trials of metformin for the treatment of ovarian cancer in Chicago, Michigan, and Fox Chase Center. And I am very happy to report that our trial is way ahead of theirs. So we're doing really good. So we're going to beat them, all of them. So there are many advantages of metformin for cancer treatment, including its low cost, oral route of administration, and low toxicity. So the main side effect of metformin is actually GI distress, which is generally manifested as transient nausea and diarrhea and rarely requires discontinuation of the drug. And then metformin is actually pretty cheap at less than $1 a day, which is really quite a bargain compared to many of the drugs we're investigating for cancer these days. So just in conclusion, there's no doubt that Taxol and carboplatin have really dramatically improved outcomes for women with ovarian cancer, but unfortunately still most women with ovarian cancer will recur and more treatment options are needed. And so the preclinical, epidemiological, and clinical data supporting the use of metformin in the treatment of cancers is building, but definitely the jury is still out. And there are multiple clinical trials in progress, including the one right here, that will help us answer that question. And so I just want to thank all those who have worked in my lab, all my collaborators, all my grant support, and then all the wonderful foundations out there who have helped move our research forward so much quicker. So thank you very much.